If you're at a pause from your dinner, there's a QR code that's the pre-assessment questions. Here it is, if you'd like to go ahead and do that. And we'll start in just a couple of minutes. Don't miss dessert.
Like you got. If you do it, I'll try and.
Yes, we're ready. I love it. We caught somebody unawares. Welcome and thank you for joining us for dinner and a show. That doesn't always happen, right? Tonight we are going to have an interactive game called Game On. And it's going to be a game about basal insulin, winning strategies from initiation to adjustment. And I'm Debbie Hennon. I'm your MC. I'm a nurse practitioner from Colorado Springs, University of Colorado Health, and I'm doing most of my live work at our local social services and food bank in Monument. So let me introduce our experts. These are the judges here, should we have any challenges. To my left is Adriana May, and she is from Kennesaw, Georgia. In the middle is Nancy DeHunt, and she is a pharmacist with all manner of letters after her name, past president from the organization and from Detroit. And on the far left is Dr. Athena Phyllis Samikas. No? Yes.
Perfect.
Perfect. And she's from Scripps Clinic in California. So let me ask you to take a 2-sentence description of your background.
Yes. Good evening, everybody. My name is Adrienne May. I'm a registered nurse. I'm a certified diabetes care and education specialist. I'm the CEO of Moving Forward with Diabetes Management, like you said, Debbie, based out of Kennesaw, Georgia. And I'm also the author of the book, Beating the Sugar Beast, Lifestyle Management for People of Color Living with Diabetes.
Beating the Sugar Beast.
Yes.
All right.
There's
Thank
no
you.
QR code for that, but you should have had one.
I have the
Nancy?
books here.
Nancy,
I'm
go ahead.
Nancy DeHunt. I'm a clinical pharmacist, diabetes care and education specialist. I work at Henry Ford St. John Hospital in Detroit, Michigan. I also work at an independent pharmacy.
Hi, and I'm Athena Philostomikis. I'm an adult endocrinologist, and I'm the corporate vice president for Scripps Health for Diabetes Services. That's in San Diego, California. And I also participated as one of the lead investigators in several of the once-weekly basal insulin studies. So I'm happy to be here tonight. Thank you for the invitation, and I'm glad you're all here.
We are very happy to have you because there will be no Stump the Professor tonight. We are so thrilled to have you all. Thank you for joining us. Now, did you notice that there are question cards on the table? We have 3 different segments in tonight's game. So at the end of each segment, if you think of a question, go ahead and pencil it in. And Joni from MLI will be around to pick those up. Now, let's see. You got the QR code, I hope. This is the pre-assessment quiz. So you do need your phone tonight. So go ahead and get that out if you haven't. Get that out now. This QR code is the pre-assessment. There's a different QR code that we'll use in the next section that will let you vote from your phone. But to start with, we'll vote with flags. Before I tell you about that, of course, we want to be sure you know we have objectives for tonight, and they're describe the novel mechanism and action, PK/PD of the once-weekly basal insulins, to apply the efficacy and safety data, integrate your role as a CDCES into this new opportunity with our type 2 patients, and then to implement patient-centered insulin regimen-based treatment plans. So we'll talk about what might be the strategies that we would use. CE for everybody, and here are the disclosures, and the instructions go like this. You will scan the QR code here to be able to vote with your phone. And we have 3 segments. One is called Myth versus Fact. And that is where the red flags come in. Do you see that lovely centerpiece? Okay, everybody get 2 flags, 1 red, 1 green. The second segment is called Case Craze. And the third segment is called Spot the Difference. And of course, we want this to be interactive, and we're happy to have questions. So write them down if you could. So we talked to, MLI especially, talked to CDCESs about this topic, and it turned out that the small subject group, 96%, didn't really feel like they were very familiar with it. And so that turned out to be the top barrier, the lack of awareness. So our goal with this program developed by MLI with a grant from Lilly and co-sponsored with ADCES is going to let us start with 2 flags, myth versus fact. What if I wanted the slides to move? Okay, so green is fact, red is myth, okay? So let's see if we can get a question up here. We might even practice. Okay, here's a practice. What's the best donut? This you'll need to do with your phone, okay? Chocolate, glaze, Boston cream, jelly. Look at glazed, for goodness sake. Powdered sugar, and who eats a donut? I don't know. We don't have any dietitians up here, so we will not be calling this contraband. Did you get the hang of how to use it with your phone? All right, thank you. They're 2 different things. The pre-survey is a different code, a different QR code. And then we just jumped right in because we want to respect your time. Okay, so let's do one more question. If your job title, oh man, here you go. If your job title were a superhero name, what would it be? Like a couple of things might be Glucose Whisperer, Captain Carb Count. I don't know, what do you think? Superhero for you. Medication Maven. The
Sugar Daddy. I like Sugar Daddy there.
Not the Food Police.
Juice Box Hero.
Juice Box Hero, that's someone who's going to camp.
Diabetes diva. That's cute.
Fiber, oh.
Sugar mama.
Sugar mama. Diabetes diva, yes. Sugar buster, sugar queen. Oh my gosh, these are great. Oh, I love it. So you guys got the hang of how to type in, how to work with it from your phone, and these are great superhero names. Do any of you have a cape? A tiara? All right, well, just a thought in case you wanted to. Okay, so for our first segment, we have 8 questions, 8 rounds, and these are myth versus fact. Red is myth, green is fact. So when I read the question, you raise your flag. And you know what? We have online participants tonight. So welcome to you. And please go ahead also and scan the QR code. And you can yell the answers if you want. That'd be great. Okay, here we go. Question 1. Once weekly basal insulins are designed with molecular modifications that extend the half-life to about 1 week. Myth or fact? Okay, we're gonna see how that goes. Myth or fact? It is a fact, indeed it is. There have been a couple of talks here about the once weekly, but we'll share data with you as well tonight. All right, here's a question. Here's the science behind that question. We're gonna pass it to Miss Nancy.
So what they did was they did a molecular modification. So normal insulin is bi-chain, has 2 chains, an A and a B chain. They took away one of the chains, so it's a single chain variant. And they modified it so that it had greater insulin receptor affinity, so it will bind to the receptor more easily. They also attached it to a protein using, what did they use?
IgG.
An IgG.
They attached it to the IgG, but they used, I'm sorry, a peptide bond. So now you have a much larger molecule, and it is less likely to be cleared. It will slow down the absorption rate and the release of that high affinity molecule that will have receptor affinity. It also recirculates. It's not cleared renally. It'll recirculate, so there's on and off binding with the insulin receptor, so it prolongs the half-life and makes it likely to last greater than a week. I think it's a 17 to 19 day half-life.
And that's F-Satura. What about Icodec, Novo's
So
product?
Novo's product is similar to their past products where they have albumin binding. So the albumin binding causes a depot in the subcutaneous tissue. It circulates in and out of the system, binding and rebinding to albumin, which also prolongs the half-life. This time we're looking at a 7 to 9 day or 7 to 8 day half-life.
You may have seen the animation at the Novo booth. It was really fascinating and really, I think, explained that nicely. So thank you, Nancy. All right, here comes a new question. Once weekly basal insulins closely mimic endogenous basal insulin distribution profiles. Looks like most of you are leaning toward fact. It is indeed fact. All right, thank you. So tell us, Nancy, what does all of this? I'm from Colorado. Are those ski slopes?
So the ski slopes that we're familiar with are the ones that are outlined at the left side of your screen. If you look at the bottom, though, you'll see that dotted line with the weekly insulin. So it's a much flatter, more prolonged action. The onset is a little bit slower because we're talking about steady state, which we're going to talk about a little bit later, but it's a little bit different than what we're used to. It's
Graph on the left, and then the PD, the pharmacodynamics, show that you have a really nice, consistent, flat glucose management effect over the entire week. This is Efsitora. If you look at the same thing on the next slide for Icodec, very similar. This has a slightly shorter half-life, and so there is a slight variation within the week in the second and third day, but this is really not clinically noticeable, especially in type 2 diabetes. A little bit different situation in the studies with type 1, but with both of these molecules over the entire week, really nice flat profile once you get to steady state.
And that's going to be that's going to be an important factor when we're doing dosing and looking at changes.
And which one's U500?
They're U700, so they are very concentrated insulins. Volume is very low, but and concentrated, but they are dose. The unit amounts are the same as what we're used to with the daily.
On both of them?
Mm-hmm.
Okay.
All right, here's our third question. Once weekly basal insulins work by providing a more enhanced glucose lowering effect than daily insulins. Myth or fact? Grab those flags. I don't know. They're running real close together. Adrian, what do you think there? That's almost an even split, isn't it? Well, hey, let's see what the answer is. That's a myth. It is not more enhanced, but it's comparable. It's non-inferior. And we'll get the data for you there. Okay, here we go. Once weekly basal insulins have more consistent fasting glucose due to reduced day-to-day variability. This one will take you 10 seconds. You guys get those flags up. Come on here. Yeah, that's exactly right. Okay, that is a fact. And you saw the first peek at that, but we'll get more data. Here we go. Once weekly basal insulins eliminate the need for dose titration. We wish, yeah. You're right. The majority, 88%, said, no, of course you have to change the dose. And that's right. You have to change the dose. So that was a myth. All right. Now, let's talk about the titration.
We'll talk about it a little bit more when we do the cases, but just in general, think about this. You are going to be titrating the doses once a week instead of once a day. And in general, if you think about the dose amount and divide that by 7, that's about what it would be on a daily basis. So this divided by 7 might be 2 or 3. That's what you might be changing when you're titrating up and down. But with the weekly insulin, it was 20 up and 20 down once a week. This was with the Icodec. With the Efsitora Alpha, there was a little bit more fine-tuning available. I'm not sure if it's going to show up here. If you're at target, no changes, but if you're above target or below target, once again, 20 up, 20 down. But here they also allowed, if you were much above target or you were having very frequent lows, you could actually adjust by 40 up and down as well. So a little bit of fine tuning here, a little bit finer tuning, but the concept remains the same. Just as with the basal, if people are running high, you're going to up the dose. If they're running low, you're going to back off on your dose.
Thank you. So 20 or 40 unit titration.
That was for the Efsitora Alpha. And maybe we could add one more caveat here. Some people are more insulin sensitive. You know, our patients with renal insufficiency, maybe someone that's a little bit leaner, maybe you don't want to go up by 20 or even 40. You might go up by only 10. That's a clinical judgment call, and we can do that as well. That wasn't what was done in the studies, but I think that will be something we see clinically in practice.
I bet we'll see clinicians make some individual decisions there. Nancy?
I would say that as you become more comfortable with using it, you'll find those nuances.
All right, so here's one more question. The delayed onset of once-weekly insulins means they cannot be used safely at initiation. Myth is red, fact is green.
I don't think we can stump this group. They're too smart.
This group is, these are our peers.
Yes.
These are our colleagues. We're all kindred spirits. So of course that's a myth. That is tested, and our online people got that 100% as well. So we are really proud of you. So the dosing and time to steady state, Nancy?
So I think this is an animated slide. So if, after the injection, keep going, you'll see that the subcutaneous is absorbed into the bloodstream. There's a slow absorption because of the larger molecules. So you'll have a steady state within the bloodstream. Keep going. Keep clicking. You have the insulin receptor binding, and then if you keep clicking, you'll see that it will keep building to a steady state, something we're not used to. Those who use antibiotics, those who use anticoagulation will see a steady state that takes some time to get to. So continued dosing will reach a steady state and a sweet spot for that person to be in the therapeutic range. We'll see the same thing with these insulins because they have such a long half-life. It might take 2 to 3 to 4 to 5 half-lives to get to that steady state. So we have to really watch and tweak as we move along the line. And then once they're at that steady state, then there are little guidelines about not only dose adjustments, but if there are changes to the patient, you may have some tweaks along the way. So important points for you to understand that there's not an immediate on and off.
So this is Efsitura, Lily's product. And Doug?
Maybe, can I jump in here just
Yes,
a minute
please.
to add? That first light blue line is exactly as Nancy was describing, longer half-life, longer time to steady state. But in the studies at least, we did give, whether you call it a one-time dose, a loading dose, there's different terminology that's being proposed, but you can get someone up to steady state a little bit faster if you give a one-time larger dose, which is what was done. That's the dark line here, and you can see that they did get to that steady state that Nancy was talking about, just a bit faster. And then those light lines in the background are daily glargine, which is what we're used to giving. You get up to steady state very quickly, almost immediately, but there's wide variation as those go up and down every day. And it's smoother with that once weekly dose.
And
That's something kind of scary because we're not used to seeing that. We're not used to giving 2 and 3 times the dose as a loading dose. But that's typically what we see in pharmacy with the antibiotics and the Coumadins and things like that. So it's a different concept, and it's going to be one that you can't be afraid of because, as you can see, it's very effective. The insulin icodec is pretty much the same. You have the albumin-bound molecules. They're slowly absorbed into the bloodstream. There's a depot, and if you keep clicking, you can see that PK profile moving up the ladder compared to if you don't do a loading dose versus if you do. So you just keep clicking, Deb.
3 clicks in 1 move. Doug, do you have a magic wand?
There we go. So the difference that you saw with the Efsitora alpha, you'll see the same with the Degludec. So don't be afraid of a loading dose if you see it, and you'll get used to it.
Thank you. All right, here's one more question. Once weekly basal insulins may help address barriers to consistent medication taking associated with daily injections. I know, yes, yes. Our online people agree, exactly, yes.
The flags are moving with the music.
The flags. This group wants to go dancing.
I can see.
They're ready. And so, of course, that is a fact. And our online folks got it right, of course, as well. So what might fewer injections mean?
Yes, of course. So if we're looking at fewer injections, of course, we're going to be looking to see more consistent medication adherence. If you have 365 injections versus 52 injections per year, more than likely that will make your patient more susceptible to use their medications because they're having fewer doses to administer. So the once weekly formulations of the endocrines are associated significantly more consistent with the medication taken than the once daily formulations. So if you think about that concept, you're going to think about the similar benefits may be observed also with your once weekly insulins. So anytime we're thinking about less, for most patients, less is more. So if they're doing less injections, they're more likely to take their medication.
Nancy, what
Can
would
I
you
just
add?
poll the audience? You can use your green flag. How many of you have patients that you can imagine would prefer only one injection a week?
That's pretty good.
Yeah, we're not surprised, are we? Both companies did patient-reported outcomes, and their results were the same. All right, here's the last question in this round. Once weekly options can replace daily options in all patients who require basal insulin. Yeah, that's, yeah.
I even heard some blues.
So you're exactly right. The once weekly isn't approved for type 1 unless you're in Canada or some other country. And pregnancy would be another place you would not use it. And Dr. Athena, you had some thoughts too about maybe not using it some places as well.
No, I actually think you nailed them. That's exactly where they're not approved right now.
All right.
The studies have been done in type 1, and we might see that down the road, and it is approved in other countries, as you noted also.
Is. All right, well, so this is the end of our very first section. Thank you very much for the flags. If you have questions that this has triggered, the question cards are on your table. So pencil in a question, and Joni is walking around if you need more cards. Now, the next thing we want to share is a vignette from a patient.
I was terrified, absolutely. And yeah, it was very scary. All of my mother's siblings died from complications of diabetes. I saw them all, so yeah. When the doctor told me I needed to go on insulin, all I could think of was these horrible, horrible shots I was going to have to take, and I didn't want to, but you know, I resigned myself to the fact that yeah, you're going to have to do it if you want to keep living. The nurse came in and she said, "This is where you need to inject." She showed me, you know, around my navel. She said, "This is where you need to inject." And she went ahead and did it. Now, when I went home and I had all my supplies, I didn't want to do it. I was by myself and I thought, what if I do it wrong and somebody, you know, and they have to come in and find my body laying on the ground or something. So I'm going to say when I was first diagnosed, I was not educated well enough. I think just somebody just taking just a little more time instead of just handing it to me and shooing me out the door. I was one of the first patients because I felt way more comfortable with someone who was looking after my sugar instead of looking after everything. And she answered the questions. She helped, I'm gonna say, relieve some of my fears that I had about it. But she didn't sugarcoat it. You know, she gave me truthful answers and things that I needed to hear and I needed to know. And she would not, she would not renew my prescriptions unless I came in every 3 months, and that, that helped a lot. Okay, we talked about all those things. The first thing that helped me so much was I told her, I said, I don't know if I am injecting myself in the right place. Because I had, in my mind, there was just about this much room that I had to inject. And she said, oh, no, you can spread out away from that. Okay, that was a eye opener. And so we have dropped my A1C drastically. I don't know if you want to know what it was, but when I first came here, it was 13.
Ooh. We've seen that before.
When I first came, my A1C was 13. And now I was in here last week and it's down to 6. Well, we've gone from here to here, terror to comfortable. It does not scare me anymore. I may die of something, but I don't think it's going to be diabetes.
Love that. Love that.
Yes.
Thank you. That's great. Thank you. Now, Adrienne, your colleague is her provider.
Exactly.
What would you add to this?
So this case right here is so amazing. I got the chance to talk to her provider, who is a nurse practitioner. She's a CDCES. We spoke on Thursday, and she let me know that this journey for this patient has been amazing. Like you heard her say, her A1C went from 13 to 6. And like she also mentioned, and this is huge, she didn't refill any prescriptions until she came in for her visits. So they had an agreement, they had a relationship, and from going from a provider that was not a CDCES to going to her current provider, who has made a great difference, not only in her diabetes management and her treatment plan and her trust. And she really trusts that her provider is going to do the best care for her.
Awesome. Thank you. Well, let's look at some case studies. So with the case studies, you'll vote by phone. So again, here's your QR code. If you didn't get it before, go ahead and get that now. So we want you to, it's here as well, if you don't mind if I keep talking. There are 4 case studies that we'll do. And once we present the case, you use your phone and you select one of the answers. Okay, and let's start with a polling question for you before we jump in. How familiar are you with the latest efficacy and safety data on once-weekly basal insulin therapy? A is very familiar, B is familiar, C is somewhat, and D is not familiar. Dots coalesce and tell you what our consensus is on this. So there are similar numbers with somewhat familiar and not familiar, but there are some folks here that are familiar, so that's great. And a few that maybe helped Dr. Athena with the studies. Look at that. Love it. So let's look at some of the cases. Here we have the slide advancer doing its own thing. Did you catch the answer? It was up there for a second. Here's a 62-year-old male with type 2 diabetes who's been on Basal for 3 years. A1C of 8, despite taking glargine U100 consistently. He reports occasional nocturnal hypoglycemia. BMI 31, he's on metformin, an injectable once-weekly incretin, and an SGLT2 inhibitor. He's doing this provider's doing the standards of care, right, down the row. But here's the concern: frustration with limited improvement despite taking medications consistently. A1C 8.1. All right, so here's a couple of thoughts. Which of the following clinical decisions might you make first? A, continue the current regimen, or B, reduce the basal insulin? So let you take a minute and vote. You guys are amazing. I mean, this is the choir, 92%. Woof, nailed it. 91%, all right. So what about the safety data? Wait.
We have.
Can you get us back to the answer there? Here it is. So reduce the basal insulin dose, and you all were concurrent with that, but what's the rationale on that? Why would we do that?
So if we're looking initially that he's already over target, we're going to say he's getting over basalization. He's having a hypoglycemia, but we're actually chasing these target A1C numbers. So we want to also look at what the driver. We need to look at the driver of what's causing these numbers to look like this. And then I know, Nancy, also you had some additional information you want to chime in with that.
Sure. So how many of you have seen the physicians just keep adding basal on? You cannot add basal and address postprandials. And that drives the lows. And so one of the first rules of insulin dosing is fix the fastings first, but also eliminate the low. So if you have a low, you have to back off the dose. So in this case, that's what we would suggest, is that you have to lower the basal dose and then look at options. If you are at an A1C of 8, you're getting a little closer to where we can't use basal insulin to address getting us further down the line necessarily. We have to look at postprandial medications.
And we have the safety data from the studies that we'll ask Dr. Athena to share with us.
Sure. So there were 2 series of phase 3 studies. One series was with F-Stor Alpha. Those were called the QUINT trials, and that's what you see across the top here. The other ones were with icodec, and those were called the Onwards trials. I don't know if those are up there. If you click one more, thank you. So what these looked at were, they were comparisons between a once weekly and a once daily in all of these. In some, it was starting out first time dose initiation, once weekly against once daily. In others, it was switching, like this case, already on insulin, switch to once weekly. And then there was basal alone and basal bolus. So that was the same way in both the series of studies, whether it was icodec or Epsitora. And they looked at what the rates of hypoglycemia were, whether you are on once daily or once weekly, and achieving equivalent A1C levels, right? That's the bar that you need to have if you want it to be able to assess safety. You have to get to similar A1Cs, otherwise you're cheating. In all these studies, I'm sorry if you could go back one, I'm not sure, this, one more? This just shows rates of hypoglycemia, and a future trial will show you the A1C as well, but they both got to equal A1Cs, which is great. What happened to hypoglycemia, equivalent rates of hypoglycemia? There was no excess hypoglycemia, whether you were in the once daily arm or the once weekly arm. So it was really nice to see that. There was slightly higher rates of hypoglycemia overall in the basal bolus. We know that's going to happen. When people get bolus added, there's higher rates of hypoglycemia, usually related to that bolus dose. And so in both the studies, there was about a 5 to 6% rate of hypoglycemia in those studies. In all the other studies, very, very low rates. And what you see here is the odd ratios, which really tells you about whether there'd be increased rates or not between the two groups, and there was really no increased rates between the groups. So this was one other interesting study and a question that gets asked all the time. What happens if someone overdoses? How many times have we had someone that maybe takes an extra dose? Maybe even more than an extra dose. They didn't remember they took it at night, they might take an extra dose. What would happen if that happened with once weekly? Oh my gosh, would they go into prolonged hypoglycemia? We wouldn't be able to get them out of it. And the answer is no. They actually did this study. Dr. Thomas Pieper did this in Austria. Gave both 2 times and 3 times the dose. There was no, and then he compared doing that with once weekly versus once daily. There was no excess rates of hypoglycemia between the groups. There was some increased rates of hypoglycemia, although not much, and they were treated exactly the same way. So when we think about what's the recommendations we give patients, the 15 rule, give 15 grams of carbs, wait 15 minutes, you guys know this better than I do. You train all the time. That is what was used and could work then to bring someone out of the hypoglycemia when it occurred, but no excess rates. And just think about, I don't know, Nancy, if you've said this example yet, but it's kind of like filling the bucket with water. And once you're at steady state and you've filled your bucket, if you give a little bit extra as a double dose, you're not giving this dramatically large dose that's going to send someone into prolonged hypoglycemia. It's just really, it ends up being just a little bit more. So you do need to be watchful. They do need to still be trained how to manage it if they get hypoglycemia, but there's not this dramatic fear or risk that they're going to have prolonged extensive hypoglycemia.
And so that term insulin stacking that we were so afraid of before is not an issue according to the studies that they've done.
Correct.
This is very reassuring because I'm sure you would think this might be one of the biggest worries. So thank you for sharing that data. Okay, here's another case. A 55-year-old female who's receiving once weekly Basal in a clinical trial. A1C at baseline was 8.4, now at 7, 26 weeks later. No severe hypoglycemia, improved satisfaction due to fewer injections. The concern, though, she has is she's wondering if she'll maintain control with continued weekly dosing. So here's a couple of options thinking about the clinical side of things. Would you recommend continuing the current regimen, A, or B, increase the weekly basal dose to a target A1C of 6.5? Take your phone out and let's vote some here. The majority of you have said continue the current regimen. There's a third of you that are saying, well, you might increase it, but it'd help to have a little more information, wouldn't it? So let's see what our panel says about this. What are your thoughts? Adrian?
I think if we're looking at the first best choice, we would just continue the current regimen.
Where's the
We wouldn't make changes currently to what she's currently doing. So the best first step would be to continue the current regimen. She's not having severe hypoglycemia. She does have a high satisfaction rate with her current treatment plan. And then also kind of pushing to less than that 6.5, depending on the case, because every patient, we all know this, every patient is different. It's going to be patient specific. But we don't want to push to that less than 6.5 because you could risk the over-basalization and the hypoglycemia without clear benefit of changing her regimen to what she's already doing. And then, of course, we all know that if you have a CDC, yes, if you have a diabetes care and education specialist working with you, we're going to take that time to provide education. We're going to see what she's currently was working for her. She's already been successful, so we want to reinforce her success. We want to confirm what she's actually saying to us. Of course, we all know this. We want to continue to do the patient-centered care. We want to hear what her concerns are, what her barriers are, what's working for her, what's not working for her, and then just keep monitoring her treatment plan to see how it's managing her diabetes.
Nancy, what would you add?
So I would say that either answer is correct. It depends how comfortable you are in getting patients to 6.5, because there are national standards that do suggest you get patients down that low. I would want to put her on a CGM to ensure that it was a safe journey down to a 6.5, if that's what her desire was, and she had no other issues. Athena, I don't.
That's a great point. We're using CGM all the time now, and for people on insulin, it is most of the time covered by health plans, including Medicare. So for insulin users, so I really like that approach, and be able to see if it's causing any hypos. You might consider another approach. I think we might talk about this later on. They might need a little bit of bolus instead of pushing up that basal further.
Exactly. All right, so some data around this.
Yeah, great, thank you. If you could click one more just so we could see everything at once. And this is that same group of studies, the Quint series on the top with Efsitora, and on the bottom, the Onwards with Icodec. And now they're showing the A1C data, which I spoke about earlier. And you can see within all the trials, the first ones are usually initiation, Quint 1 and 2. Then 3 was basal switches, and Quint 4 was basal bolus. You can see that the rates of drop of A1C between both groups were very equivalent. In that series of trials, the starting A1C levels were between about 8, 8.1, and they were still able to get them down by a point or so, in some cases even a little bit higher in A1Cs. So in the Onwards trials, very similar. They started out with slightly higher A1Cs in the 8.5 or so range, but again, very equivalent drops. In some cases in that series of studies, they had superior drops in A1C, so greater drops in A1C than the once daily, and yet still had equivalent rates of hypoglycemia between both groups.
What about the CGM data?
Right, so some of these studies included CGM, as Nancy spoke about, which is really wonderful because then you get to see both time in range as well as hypoglycemia throughout the entire 24-hour time period, or the time that this was captured, 14 days, whatever it was. This is important because when we were doing studies with point of care only, sometimes you would miss. Someone might have an overnight low, someone might have later in the day low, and that was not captured. So with the CGM data now, you can see what happened throughout the entire time period they were on, and had their numbers captured. And you see once again, baseline are the first couple lines there. This and the Quint study between Efsitora and Degludec in that case. Started out fairly low time in range when you're looking at that. It's a little bit small for me here, about 35, 36%. But they went up to nearly 70%, which is about where our target is that we want. That's a really nice improvement, about the same between groups. And then look at that hypo rate, both for level 1 and level 2s. There was slightly higher in the once weekly, but not significantly higher, and really very close. And overall rates, you know, what are the guidelines? What do they tell us? They want less than 4%. And look at what this was, well below 1-2% rates in this time period. The Onwards 9 was with insulin Icodec. This was a single-arm study where they were just doing titration up at baseline as they were bringing someone up to target. And when you have a CGM, once again, you're allowed to see it. It allows you to see what's going on. Might back off if there was any hypos. And they also went very nice improvement in time in range there as well.
I think this is really reassuring. We think about A1C being the North Star, but when we're adjusting insulin, CGM has
Totally
to
agree.
be there. Thank you. All right, here's another case. This is a 68-year-old male with 10-year history of type 2. He's on multiple daily injections, recently began missing evening basal insulin doses, has mild cognitive impairment, and the concern here is the difficulty maintaining his medication taking. So here's a couple of things we'd like you to consider. So please take out your phone and let's vote. Would you switch to a weekly basal insulin? Or B, would you discuss medication taking strategies and continue with the current regimen? So if you would, please go ahead and vote on what you would do first. Well, so the vast majority of you did indeed think that we might consider switching to once weekly insulin. Both are correct answers, though. Wouldn't you agree, Adrienne?
So I think when we think about somebody that has a mild cognitive impairment, the first thing I would think about is, do they have a support system? I would think about that first. And then I would think about, yes, the simplified plan for management would be switching them to a once weekly basal insulin. You also want to think about, will they be able to keep up with their regimen? And a simplified plan with the once weekly basal insulin would be easier for them to do than their current regimen. You would also want to talk to their family. So when I think of management, I always think of, what does your support system look like? Do you have somebody who can come in and help set up your medications? Do you have someone who can make sure that you're getting the right dose? So if you simplify that for them, that would make their management a lot easier. And then of course, we all know with CDCES, we can help the patient and their care partners with that regimen, with their routine. What does it look like? Do they have somebody who can come in and help them manage that? So that will help them with their plan as well.
Right.
It would also help with family members because you know that you have that weekly steady state. So if they came on Saturdays and 1 week they had to come on Sunday or Friday, I think it would be safe enough for them to be able to alter the regimen. It's not something we would suggest, but if that's the routine that would help them most, then we don't want to miss the doses.
That grace period is what you're alluding to. We'll talk about that in a minute, a little bit more. All right, so would you share some of this data with us on the dosing and titration?
Sure. So this is the way we dosed in the studies. On the top here is Icodec, on the bottom is the Efsitora. It's a little bit flipped this time from the other studies, but if someone is starting for the first time, they're on all those other great meds and their A1Cs are still elevated, and you're thinking, yep, this person should be on the once weekly insulin. If you're going to consider Icodec, 70 units once a week is what was started in the studies, and then titrated up from there, about 20 up, 20 down, once a week, based on what that fasting blood glucose was over the past 3 days. So, and think about this, if you divide 70 by 10, by 7, what is that? That becomes 10. It's as if you were starting with, let's say, 10 of basal daily insulin. It's that same concept. The Efsitora, slightly different, same concept. Their starting doses were either 100 or 300 units once a week. And that depended a little bit on if they came in with lower A1Cs, you might start with that lower starting dose. If they came in with slightly higher A1Cs, then you want that option to start with a little bit of a higher dose. And then once again, titrating once a week thereafter with that previous titration regimen I showed you for the Efsitora. 20 up, 20 down if you needed, but you could go up as high as 40, depending on how high they were.
And the pins are in 10-unit increments. So that's sort of, I think, the reason we look at those even numbers.
Correct, that's exactly right. It does come in pen only, and it's 10-unit increments. And then using a CGM, traditionally, I think you heard Nancy say earlier, fix the fasting first, because that's what we had to measure. You would measure a point of care with a fasting number. But now if we're using CGM, how would you use a CGM? You could look at the fasting on the CGM, and if it's persistently elevated, go ahead and increase your dose. But you should also be looking at if you're having hypos at any other time of the day. That's that beauty of CGM. If you have, let's say, fasting at target, but you're having hypos other time of the day, I would consider backing off at that point. You don't want those hypos. That's dangerous. That's a reason to titrate down.
Right, and if you were to look at a whole week's worth and they only had one hypoglycemic event, then you have to start asking questions. What did they eat? Are they skipping dinner? Are they on a GLP-1? Are they getting nausea? Were they sick? So there are other questions to dig down to find out if in fact they need a dose adjustment or if there are underlying conditions that predispose them to one hypoglycemic event.
Pattern management 101.
Absolutely. Can I just add one more thing though to that, Nancy? Skipping a meal, theoretically, if you're on the right dose of basal, should not result in a hypo. So if you are getting that, it's a great question to ask, because if you are seeing that, then you are probably over-basalized and you should back off a little bit. So it's a little bit of a clue and a hint.
All right, thank you. So here's our fourth case in this section, a 59-year-old female with type 2. She's on a weekly GLP for 6 months and she's taking it consistently. A1C is now 9.1, down from 9.9. BMI is 31 and it was 33. So we're looking at this and discussing basal insulin options. She's expressing concern, though, about daily injections and weight gain because she's lost 25 pounds, and she's pretty happy with that. So which of the following decisions might you make first? So let's let you vote again. A, delay basal insulin initiation due to her concerns, or B, initiate basal insulin of her choice. So go ahead and vote again if you would. Have you got your phone handy? The majority of you are saying look at a basal insulin of her choice. And so let's discuss that a little bit. She doesn't want to gain weight. What is the weight data?
Here's the answer.
So the answer for this is we're going to still initiate the basal insulin, but we're also going to offer her feedback and get suggestions from her and offer her treatment options. So we don't want to delay it for her numbers to get higher, but we do want to offer feedback from the patient. Of course, this is their treatment plan. We want to make sure that they understand their options. We always want to offer our patients all the treatment options and what they're willing to do, because we're only with them for a limited amount of time. I know I'm preaching to the choir. I know we do this each and every day, but we're only with the patients for a limited amount of time. It's totally up to them what they're going to decide to do and what they're going to adhere to once they leave our offices and leave our visits. So the A1C 9.1 is above the target on that GLP-1 alone. So she does require or need the basal insulin to get her numbers down and on track. If we delay the treatment, it's going to worsen her control of her diabetes. So she's lost the weight. She's proud of that, and we're proud of that with her too. We want to reinforce that. And I know she's concerned about gaining weight, but we do need to have an open and honest conversation with her just to see what she's willing to do and what treatment plan she's willing to work out and to manage when she goes home.
Part of that weight loss may be poor control of her glucose. So I think, right. I would agree. We've got to get that control tightened up. Nancy, what's your thought?
I would make two suggestions. I wouldn't force her to go on a basal if she's not ready, even though that's the best choice for her. But I would arm her with the technology of CGM so that she could come to the conclusion that that's what she needed. I would also point her to the peer support communities. These are the people that are going to talk to her on a one-on-one basis, and she'll get community support. Those peer support communities, we heard about them this weekend. They're important. They give people the confidence to know they're not alone. They'll address the fears on a peer-to-peer basis. Mm-hmm. It's a different conversation. And then when they come back, we can help them navigate. So there are opportunities here, and we are the ones who are supposed to help them and help them navigate to the answers, but we want them to be a part of the decision instead of trying to push them too much in the direction that we know they need to go. If we wait another couple weeks and let her see and let her come back to us and say, I'm ready for it now. I've talked it out. My fears are less. She's already on a once weekly GLP-1. It's not a fear of injections. She's afraid of weight gain, or she heard something from other people about that insulin is bad for you. So give her an opportunity to come to her own conclusions.
Thank you. What about the missed basal insulin?
This was based on a study that just looked at if you miss even 1 or 2 doses of your daily basal, it can result in an elevated A1C. So any ways that you can go ahead and improve adherence, such as with a once weekly, that may allow better A1C reduction overall.
And her concern was weight gain. What did the study show us about weight gain with once weekly?
Yeah, we know that when you start insulin, you get weight gain associated with it. And we saw that in these studies too. Although there wasn't that much weight gain, it really was between probably 2 to 4%, and it was equivalent between. Didn't matter again whether you were on daily or weekly, similar amount of weight gain. There was one of the studies that did not have any weight gain, which is crazy for me because the A1Cs did improve, but that's really not the norm.
It's magic.
Yeah.
So Adriana, what about shared decision making? Give us just a couple of minutes on your thoughts here.
Yeah, so just like Nancy mentioned, it's all important for us to always make sure that we're including the patient. It's going to be a shared decision. It's not going to be, you take this insulin now, you need this, you need to take this basal insulin. No, we need to hear what their concerns are, what their fears are, what they're reluctant about. I've had patients tell me, I'm not going to take this medication because I had a family member take it, they had a bad reaction, something really bad happened to them, so I'm not taking the medicine. We have to respect that. We have to respect what they're willing to do and what they're not willing to do, and then offer them all the treatment options. And then also, it's very important for us to assess the social determinants of health. If they can't afford the medication, we can write prescriptions all day. We can recommend things all day. We need to address what's going to be a barrier for them. Do they have transportation to get to the pharmacy? Can they afford the medication? Do they believe that the medication will work for them? So all the barriers related to the SDOH, we have to address those and see what's going to work for the patient and what they're actually willing to do.
I think part of the education always includes, it's not your fault. And beta cells don't regenerate. And I think when we share that with people up front, they know they may need insulin somewhere down the road. I've been really amazed to see the change in that with GLPs. It seems like we're not starting insulin on patients as soon as we used to. And so I think that good education, especially when people are starting with their diabetes, helps them be able to kind of process things down the road. So we're done with this section with Case Grays. Thank you very much. Now, do you have questions? Pencil out some questions if you do. Our last segment is very fast. This is one you guys are just like going to go, oh, of course. But we're going to zoom through some language, some conversations. This one is called Spot the Difference. So again, we're doing the same QR code, so you can do it with your phone. There's 4 rounds, there's statements, and here's the first one. What would you say that would be more acceptable? Hey, you need to start insulin because your blood sugar's too high. It will improve your glucose control. Or, would you be open to talking about how adding basal insulin might help improve your glucose and your overall health goals? So which one of those do you think is most appropriate? Patient-centered.
100%. 99.1%.
Yeah, that 1%'s an error. Someone pushed the wrong button and drove it. Yeah. So yes, exactly. All right. So the better answer would be, would you be open, right?
Yes.
Adriana, what's the rationale for that?
Well, the rationale is that I always like to say this is the patient's treatment plan. We're here to educate them, to provide the best information and knowledge, but definitely I would never say you have to take this insulin, this is going to lower your blood sugar. No, I need to get the patient's perspective on what they're willing to do. What are even their thoughts on insulin? You know, do they understand how the insulin is going to help their health, how it's going to help their diabetes management? Are they going to be willing to do the injections at home? So active feedback, it's a partnership. It's not a dictatorship, it's a partnership.
Right.
And who is always at the center of the decision-making tree? Patient.
Right.
Yes.
That's right. Okay, here's another question. I can hear the parts of your insulin routine are working well and other parts feel challenging. Let's look at what's getting in the way and find strategies that fit your day-to-day life. Or, you need to take your insulin exactly as prescribed. That's what will get your glucose under control. We've never heard that before, have we? All right, yes. I mean, 99%, you don't even need to vote. We know the answer.
I
All right.
think they forgot about the language paper.
Yeah, the language paper, ADCES.
Nothing.
You can get it from the website. Yeah.
Don't use that word control.
Yeah.
Exactly.
So
Exactly.
this, of course, is a better choice. I can hear parts of your routine are working well and parts are not. What's the rationale for that?
So we know the rationale, right? We want to actively listen to our patients. They're telling us their stories. They're telling us what they're dealing with day to day. So we want to actually listen to what's working well, what's not working so well, what they're willing to do, what they're not willing to do. And then let's kind of map out day by day, step by step, what's going to work for a strategy for them to manage their diabetes.
All right, thank you. Here's some. Look at these comments. There's a new once-weekly basal insulin available. Would you like to hear how it compares with your current daily insulin and whether it might fit for your routine? Or, there's a new once-weekly basal insulin available. It works differently than the daily basal insulins. I'll switch you. All right, do a quick vote here, you guys. All right, we know 100%, absolutely. So Adrienne, what's the rationale for, would you like to hear it, that answer?
So being that you all got 100%, we all know the answer to this, right? We all know the answer to this. We actually just want to involve the patient. It's patient-centered care. It's patient autonomy. We're letting them be involved in their care because guess what? It's their care. They're going to go home. They're going to manage it. We all know this, but we just always have to look at our tone, what we're saying, and how we're saying it to our patients. And it's informed choice, and it's also patient engagement and letting them make the best choice for their decisions.
You know, that reminds me, we've learned over the years that body language and tone are much more important to the message people hear than the words we say.
Exactly.
Yeah.
Exactly.
All right, here's the last question in this section. Realistically, you need to lose weight and exercise more to control your diabetes. And, oh, by the way, be careful with hypoglycemia. I know. Or, hey, let's talk about small lifestyle changes that could help you lose weight and improve your energy and blood glucose. Then let's review how to safely monitor for hypoglycemia. Are you already voting? I bet you are. Yippers.
100%.
All right. Okay. Thank you. Oh, yeah. Okay, so
Slightly.
the answer that's probably most patient-centered is, oh my golly, there's 49 questions. You better hustle along here, girl, and talk about why that's a better answer.
Yes, ma'am. Yes, ma'am.
Thank you.
So really, again, we all know this, right? What I always like to tell my members and my patients is, let's set up some SMART goals. If you say you need to lose 100 pounds, yeah, right. That's not gonna work. That's not gonna go over very well. But if we set some small, realistic goals for them that's achievable, and we know this, we do this every day, but we just wanna make sure that the patient is involved. We wanna let them self-monitor safely. And then you wanna integrate that lifestyle coaching. So if you say 1 to 2 pounds per week, or maybe 5 pounds per month, versus you need to lose all of this weight, that's gonna make a lot of a difference for them to realistically meet their goals and feel like they can manage it. And again, it's patient-centered care. It's really involving that patient to make those changes for themselves.
All right, thank you. Anybody else want to add anything there?
Oh, we have a lot of questions.
Okay,
I
we
guess
do. All right.
move along.
So thinking about what we've talked about, every scenario, the CDCES was able to kind of convert that bossy directive into something that is much more collaborative and translate the evidence into patients' language, clear options, shared decision, and the partnership is, of course, so important. So thank you for doing all of these things. Are you ready to jump right into some questions? The credit is just like it is with all the other programs you've attended, and so you would be able to get that on your phone under Claim Your CE, And this QR code would let you have the slides, if you would like them, and some patient aids. There's some handouts that you might find useful. But, are you guys ready? Because, here's the first question. Because we inject so much of this insulin and it stays in the body for longer, will it make patients more insulin resistant? Any thoughts on that?
Yeah, not really. It really has a very similar effect, as you saw in the studies that I showed, to daily insulin. So you wouldn't expect it to have anything different than the daily basal. But we talked a little bit about there is going to be a little bit of weight gain, and depending on what else they do with their lifestyle, if there's weight gain, that can contribute to insulin resistance. So, thinking about how we can partner it with the same medications we're using now, the GLP-1s, a few of the other medications would still be a good idea.
Which leads into the very next question. Can we use it with prandial insulin? Can we use this with mealtime insulin?
Yeah, absolutely. There was a basal bolus study in both the different once-weekly insulins. Worked very well, and very similar manner, except that you're dosing the basal component only once a week, and they're dosing their bolus with the meals that are recommended.
And what's the ratio, basal to bolus? Is it?
It was close. I don't remember the exact, but it was around a 50-50. It wasn't exactly in the studies, and each one was slightly different. Nancy, I'm sorry, you have something else.
I was just going to say, we still have insulin sensitizers, so we still have pioglitazone, which is something that Ralph DeFranzo still swears by, and we still have exercise, which helps us. So as they lose weight, if they're on a GLP-1 or an SGLT2 and they're losing weight, that insulin sensitivity is going to be upregulated a bit.
And if you don't go above 15 on PO, I think you don't see the weight gain that we used to worry about.
Correct.
All right, thank you. So do patients stop the once-weekly insulin before a procedure that they need to be fasting? And talk about that.
Yeah. Is it okay if I take that one?
Yes, please.
That has hit on probably the most common question I am hearing now across endocrinology, primary care, educators, everyone, pharmacists. There are some guidelines out of Canada where they've been using this a lot longer, and icodec was just approved here, and I believe Efsitora is going to be right behind it with the FDA, very close. So we have to think about this and what kind of guidance we're going to give people. Currently, the way the Canadians recommend it, if it's the slightly longer acting one, the Efsitora, stop it 4 weeks ahead of time. If maybe even longer than that, it could be even up to 8 weeks. It takes about 3-4 weeks for that to get out of your system. At that point, you might want to switch to a daily, go ahead and do the procedure, and then switch back to your weekly. If it's the icodec a little bit shorter, you stop 4 weeks ahead, then by about 2 weeks before the procedure, you might start daily. I have to tell you that in the back and forth that we've had in huge online questions about this, realistically, I'm not sure how much we are going to see that. If we could get people to stop them even a couple weeks ahead of time, it's probably going to be okay. And just think what we said earlier, if it's a true basal dose, it shouldn't drop people too much. So can we put them on CGMs? Can we do something else to monitor and see if they're dropping or not? And then during that procedure, 24 hours, whatever it's going to be, it's usually a procedure, colonoscopy is 30 minutes.
Right.
Can they, monitor just during that time? And I think we're going to learn a lot as we're using this.
Nancy, what would you
And
add?
sometimes those emergencies are unplanned. So if they go into the hospital should be able to regulate using IV glucose infusions. So it shouldn't be a worry. If they need correction insulin, they can always add it on, and they would definitely just be monitoring.
I think that's really important because once you give it, you can't take it back. So if someone's got an emergency and they're hospitalized, we're going to have to do a lot of glucose monitoring and maybe some IV glucose. Yeah.
There were 2 publications, both Efsitora and icodec did this, and several of us that were investigators aggregated. It was data that came in as adverse events during the trials in people that were hospitalized, both for surgical and for internal medicine reasons. And it didn't look like there was excess episodes of hypoglycemia, but don't forget, during hospitalization, they were not capturing their study glucose levels. They were only getting tested in the hospital, and that data was not available to the people that put together the statistics on this. But the majority of, in both Icodec and Efsitora, they remained on their insulin and continued to the end of the study. So it didn't deter them from using it afterwards, and there were not any excess events that were really reported within any of the groups between the control and the insulin once-weekly groups.
So we alluded to it, but would you clarify if someone misses their dose, can they take it the next day or 2 days? Would you clarify that for us?
Sure. In the studies, the way we did it, if it was within 3 days when they realized that they had missed it, then we said just go ahead and take it again. And then sometimes if it was about 4 days or more, then they could take it on that day, but then they reset that weekday. So you reset, usually taking it on a Sunday. Now you remembered, oh my God, I missed it. It's a Thursday. Your day gets reset, and it's once a week every Thursday. That's the way to do it. Or you just skip it and restart again on that following Sunday, whatever your usual day is.
You know, I don't think we talked about candidates, and would you discuss who might be best candidates for this once weekly?
Well, I might. I don't know if anyone here, Adrian or Nancy, do you have some thoughts on this? Because I think we all see patients like
I think we polled the audience, so everybody says they can think of somebody. I mean, if I were on insulin or I saw my parents on insulin, it would be nice to offer them just 1 injection a week if I knew it was safe. And from the data that we have, I would feel confident in suggesting that.
Yeah, I would think the same thing. If you're looking to simplify what you're currently doing, like we talked about earlier, if you're looking to simplify what you're currently doing to manage your diabetes management, that would be a choice.
Well, we talked about cognitive impairment and simplifying the regimen, but you know, I think about people who are working swing shifts and they don't know what day it is or when they're able to sleep. I mean, that to me might be another consideration. You know, not just our people that are struggling with some of the things we talked about. Yeah. Okay, we have 21 seconds. Well, when will it be in the local pharmacies? So Icodec is tomorrow, and Efsitora is not yet approved, expected yet this year. So that takes us to the end of our time. So let me say thank you for joining us and for all these great questions. You guys were awesome.
Yes.
Thank you to the panel.
Thank you.
Thank you. Great job, everyone.